So what is the antidote to the healthcare crisis that you describe in your book?
The crisis that we have is one of both lack of insurance, but more importantly, an unsustainable growth in costs, as well as the fact that most people, even with insurance, aren't getting the care they want. The quality isn't as good as it ought to be. Medical interventions are often not nearly as safe as they ought to be. And so the underlying crisis is, how do we improve the delivery of care? And so that's what I'm trying to deal with.
Well, I would imagine that we have to start by defining what the problem is. How would you define the problem?
The major problem is that there isn't good coordination and information flow for clinicians to make good decisions about not just their own services, but what services to order for their patients, how to make referrals to the most appropriate clinicians, how to help patients move through the system. Everything is very fragmented, and we need to change that.
Do you think we need some kind of national health care system? One of the big debates is whether health care should be, some people would call it socialized medicine, where the government runs this bureaucracy. Some people say it should be private enterprise. Each doctor is a private businessman who runs his business as he sees fit.
We actually need both. What we need is a single structure for everybody to be enrolled in, a coverage pool, to make sure that people who are sick are subsidized by those who are currently healthy, to make it affordable for people to get coverage. What we don't need is a large bureaucracy to actually operate the system, to decide what services ought to be provided, what drugs ought to be covered, what devices ought to be used. Those really need to be made by clinicians and patients, often on a one-by-one basis.
I think now they're often made by representatives of the insurance company determining what procedure you're allowed to get.
That's right, and that doesn't make any sense at all. So what I'm offering is a system whereby most of those decisions get moved away from external third parties. So, for example, on the inpatient side, I would bring together physicians, hospitals, and other people who are involved in the care during that inpatient episode, which includes a little bit of pre-admission workup, testing, things of that sort, and some post-discharge care, and provide them with a bundled payment. And that bundled payment would be based upon the resources used by those teams that get better than average outcomes. And then it's up to the clinicians and the hospital and the staff to figure out how to most effectively use those resources.
One of the big problems is the cost of medical care. There are some procedures that may do marginal good that are extremely expensive. Mm-hmm. So what's the concept with cost cutting? Should we focus on general health care, which is cheap, compared to super expensive, super specialized procedures that only benefit a very small number of people?
I think there are two aspects to that question. There are some small number of people with rare diseases where the treatments are very expensive. And if they don't get it, they die. I would argue that socially we ought to pay for those things until we decide not to. But that ought to be an explicit decision. Far more money is spent, however, on treatments that are good for some people and really benefit most others very little. There's a lot of back surgery that's done for patients who could probably do perfectly fine without it. There are a lot of expensive medications that are used when less expensive ones would be perfectly adequate. So I think we ought to have new incentives, and I think they're relatively easy to incorporate, for clinicians to think more carefully about whether the less expensive, more generic, off-the-shelf kind of intervention works.
When you say new incentives, do you mean economic incentives?
Economic incentives and also better information. So, for example, if primary care physicians find that other primary care physicians are treating similar patients much less expensively using first-line drugs instead of third or fourth generation drugs and have the same outcomes, they may start deciding, I can benefit my patient's bottom line, by making that decision to order more appropriately. And they will ask for information, unbiased information, about which drugs are valuable for which patients.
So does there need to be some kind of communication system in place that makes it easy for everyone to put all the information they have in a place that it's visible to everyone else at a glance?
Absolutely. And part of what my proposal has is, in essence, by the underlying payment system, capturing that data as it's flowing through, initially for payment purposes, later on for more clinical operations, and pulling that into large accessible databases on a routine basis, and then making that available to people who analyze the data in response to demand by clinicians and patients for better information.
Now, very often, if a person is told by his doctor that he needs surgery, he'll want to get a second opinion. Is one second opinion enough? Is there a way that a broad group of physicians can take a look at this case and all give a quick input, even if they don't necessarily see the patient, but have something to contribute to determine if this surgery is really necessary?
I could imagine that one can start looking at patterns of data and seeing, well, we have here 500 patients with a problem like mine. What's happened to, what did they have? Who had surgery, who didn't? What happened to them down the road? That's using collective intelligence. You might have something new set up. As we've moved to a digital technology, you can have an MRI scan or a X-ray done and send it to 20 different radiologists to interpret as quickly as one. So yes, there's lots of ways in which we could use multiple opinions of clinicians around the world.
And radiology is something where signs are often hard to detect, and one person might see something that somebody else doesn't see.
And in fact, there have been good studies that show that even with the same X-ray and the same radiologist looking at it a week later, they often see different things. So then the question is, this is a signal detection problem. And how does one weight those opinions? Maybe you say, well, let's just give it another 2 weeks and see what happens. Maybe it goes away. Maybe it's not problematic. So it's pulling in as much information as you can and thinking about often the best diagnostic tool at its time.
Now, one of the most complicated things is the payment structure. So if this is a national organization, let's say that surgery costs more in California than it does in Alabama. Should people in Alabama be paying for people's surgeries in California, or should there be, sub areas?
Well, I think there are two questions that we need to look at here, and it's important to distinguish if surgery is more expensive in California because the cost of living is higher here, because land is more expensive, so rents are higher, et cetera. But wages are also higher, so Californians will end up spending more than people in Alabama. What we shouldn't be paying differentially for is if surgeons just do a lot more things in California. Okay, so we need to look at where is the style of practice leading to the best outcomes.
There's an incentive for doctors to recommend tests that may not be strictly necessary. You could offer them, they may not do harm, but economically they benefit principally the service provider. Can we get a hold of that?
Absolutely, because if the primary care physician is integrated with a payment system, which is what I've built into this, and the primary care physician's decisions about what tests to order, et cetera, or his referrals or her referrals to other specialists who order tests, those will come back and impact the premium for all the patients of that primary care physician.